Welcome. I'm Dr. Caroline Kamau-Mitchell, and today I'm going to talk to you about the effects of the coronavirus pandemic and other outbreaks and post-traumatic stress among healthcare staff. The coronavirus pandemic has been an international health emergency. It's had a profound effect on the working lives of doctors, nurses, and other healthcare professionals. I'll start by telling you a bit about the pandemic and how it was caused by SARS-CoV-2, which is more commonly called coronavirus, COVID-19, or the novel coronavirus, novel in the sense that it was new. The coronavirus pandemic spread because there was a wave of infections across the world. It started towards the end of the year 2019 and to some extent continues to this day. I'm going to talk to you a bit about the psychological impact of the pandemic on doctors and nurses, because there are few times in modern medicine where a novel virus has infected millions of people worldwide and rapidly made its way across people, homes, and workplaces, grinding society to a standstill and killing millions of people worldwide. To give you an idea of just how prevalent coronavirus has been worldwide, a systematic review and meta-analysis by Rostami et al. In 2021, published in Clinical Microbiology and Infection, analyzed 47 publications and estimated that 263.5 million people were infected with SARS-CoV-2. Significant numbers of patients became seriously ill with the coronavirus, leading to over 6 million deaths worldwide, and over 170,000 deaths in the United Kingdom alone. Now, having considered what the coronavirus pandemic was in terms of its global and national impact, I will now tell you a little bit about why the coronavirus pandemic was an important workplace stressor for doctors and nurses. One reason is that the virus had a devastating impact on patients, leading to a large number of hospital admissions. In the UK alone, there are over 800,000 people who had coronavirus-related admissions into hospitals. And that dramatically changed the patient caseload for doctors and nurses and led to larger volumes of patients than normal being admitted with acute or life-threatening symptoms. And this leads me to my second point, explaining why the coronavirus pandemic is an important workplace stressor for doctors and nurses. My point is that patients who were admitted into hospital with coronavirus tended to be severely ill and at risk of death, which many doctors and nurses found distressing. Patient mortality can make healthcare staff feel helpless, and it can reduce their sense of job satisfaction. Now, I will talk about that slightly later, but I'll talk about the direct evidence about this later on. But we must start by noting that by October 2020, a few months after the pandemic began in the UK, a survey by the British Medical Association found that 43% of doctors were suffering from work-related anxiety, burnout, depression, emotional distress, and stress, or any other kind of mental health condition, which actually was worse after the pandemic than before it. Now, later on in my talk, I'll tell you why that was not circumstantial evidence. But let me go back to my point about why the coronavirus pandemic is an important workplace stressor and why it's a subject of my talk today. A second reason why many doctors and nurses found the coronavirus pandemic very stressful is that they were at an increased risk of being exposed to and infected with the virus. They became afraid that going to work in a hospital or another healthcare setting, such as a GP practice, was going to be the vessel through which they were infected, the vessel through which their own family members or loved ones were infected, and the vessel through which they could put themselves or their family and loved ones at risk of death. I will tell you later on in my talk about the data directly relating to doctors and nurses' fears about being infected, and actually why this was a highly, highly traumatic event. But let us note before we go that at this stage, we must note that it was indeed true that infections have been more prevalent among healthcare staff than among the general population. I speak specifically about coronavirus infections. Let's think about a systematic review and meta-analysis published in the International Journal of Environmental Research and Public Health, which estimated that the pooled prevalence of coronavirus infections among healthcare staff, and this was based on antibody or PCR tests, was between 7 to 11%. And that might sound low, but actually when you think about the numbers of healthcare staff that we have, that's a very, very concerning percentage. For example, there are over 160,000 doctors in the UK alone. Therefore, 7 to 11% is really not an insignificant number. In contrast, the meta-analysis I mentioned earlier by Rostami et al. In 2021 estimated that coronavirus had a pooled prevalence rate of 3.38%, and that's across the general population. Therefore, you can see, comparing the 7 to 11% with the 3.38%, that you can see that the meta-analysis suggests that doctors, nurses, and other healthcare staff were indeed more likely to be infected with coronavirus. What's more, doctors, nurses, and other healthcare staff are more likely to become severely ill compared to the general population. A study published in the journal Occupational and Environmental Medicine and reported in the BMJ, that's the British Medical Journal, drew on data from the UK Biobank study and infections data, and it's estimated that the healthcare staff was seven times more likely to have severe symptoms of coronavirus than many other workers. Now, 7 times is a very, very, very elevated risk. Doctors and nurses therefore had legitimate reasons to feel afraid of being infected and legitimate reasons to feel afraid of infecting their families. And so this can explain the impact on long-term trauma and, more correctly, the impact on PTSD. The third reason why many doctors and nurses found that the coronavirus pandemic was very, very stressful is that there was very poor availability of personally protective equipment or PPE, particularly in the early days of the pandemic. There were many people who felt very frustrated, angry, grieved. If you remember at the time, the media reports, if you're a regular reader of the BMJ like I am, and the way that doctors, nurses and other staff were talking about their frustration and anger because the people responsible, such as hospitals and governments, were very slow to provide PPE. And particularly in the United Kingdom, they were actually shockingly resistant to even providing PPE in the first place. And staff in some settings actually found themselves in trouble for wearing PPE. Now, the World Health Organization at the time in March 2020 wrote about the Ppe shortage. And there are numerous articles about the shortage, as you can see from an article in Lancet Infectious Diseases in July 2020, and last year, 2021, an article by David Oliver, that is, a consultant in geriatrics and acute general medicine, who wrote about statistics revealing the NHS PPE shortage in the British Medical Journal. Now, anyone listening to this talk in years to come might find themselves shocked that there was a lack of PPE. They might find themselves absolutely shocked that hospitals and governments were initially reluctant to accept that PPE was even needed in the first place. But let's remember one major thing. In the early months of the coronavirus pandemic in the United Kingdom, the government and its chief scientists were telling the public that SARS-CoV-2 spread mainly through touch, and this is why they concentrated on the message about washing your hands. But they ignored the importance of airborne transmissions, and we know since then that coronavirus is spread primarily through airborne transmissions. Not to say that touch isn't important, but in terms of probability, one is more likely to catch it through somebody coughing, sneezing, or breathing into the air. And therefore, PPE equipment such as face masks and face shields as well was really, really, really important at the time. Now, I believe this mentality spread to approaches that the government had of not really prioritising funding or pushing for PPE quickly enough. Now, having told you about the hard data relating to the coronavirus pandemic, and just to give you a kind of insight into why it's psychologically important as a workplace stressor for doctors and nurses, I'm now going to turn to discussing the impact on their mental health. I've so far spoken about distress in the sense of a variety of symptoms. For example, I told you about the BMA survey, actually not the BMJ survey, so it's British Medical Association survey, which found that 43% of doctors were suffering from work-related anxiety, burnout, depression, and emotional distress. What I'm arguing in my talk today is that we need to delve a little further into the specific types of distress, focusing on the risk of specific mental disorders, not symptoms per se. I teach about psychopathology and work, and one of the things I tell my students is to be wary of a symptoms-only approach to understanding workers' distress, because symptoms by themselves are not necessarily indicative of clinically significant distress or disturbance to a worker's daily functioning. Symptoms alone are normal. They're normal human reactions to stresses. For example, if you have a challenging exam ahead and you feel anxious for a week, that does not mean you have an anxiety disorder. Absolutely not. It simply means that you have reacted quite normally to an event that you find potentially stressful, and that anybody or most other people would also find potentially stressful. So feeling stressed, burnt out, depressed, anxious, or otherwise distressed by the coronavirus pandemic, if you're a doctor or nurse, is absolutely expectable, it's absolutely normal, and it's absolutely not a clinically significant reaction, because it's a non-clinical reaction to a real stressor. What we need to consider here is not the symptoms per se, but whether they meet the criteria for a diagnosable mental condition. So therefore, clinically speaking, we must be careful to point out the difference between symptoms and illnesses. Of course, symptoms are important in and of themselves, and it's important that they're examined in certain types of research. So I welcome seeing data about that published, but I argue that we need to go a step further and consider the clinical impact of the coronavirus pandemic on doctors and nurses in terms of their mental health. I argue that we need to examine cases where the symptoms suffered by doctors and nurses met diagnostic criteria for mental disorders. Particularly, a key criterion for diagnosis in most mental disorders is that the symptoms have negatively impacted a person's functioning at work, with family, in social settings, or in any other significant context to a significant degree. So there has to be clinically significant distress or impairment to their normal functioning. Now, today I will focus on PTSD, or post-traumatic stress disorder, and I'm interested in examining data which concerns PTSD symptoms that meet diagnostic criteria for the disorder based on ICD-10, ICD-11, or DSM-5. So this is to say the International Classification of Diseases, that's the ICD, or the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, that's the DSM. Now, in my teaching and in today's talk, I'm going to focus on DSM-5 because it's the most popularly used manual, really, within clinical practice and research within my field. Although I must say that the ICD is also quite commonly used in some countries as well. Now, the reason why I'm using DSM-5 and not DSM-5-TR is because although the APA, the American Psychiatric Association, has recently released DSM-5-TR, I'm going to focus on DSM-5 because it was valid during most of the coronavirus pandemic. It's a popular approach used by clinicians and researchers worldwide, and DSM-5-TR has only really recently been submitted and released to the public and clinicians. So before I talk about the data concerning the prevalence of PTSD among healthcare staff following the coronavirus pandemic and following previous pandemics, epidemics, or outbreaks, I will start by telling you what PTSD is. What are its symptoms? What are the DSM-5 criteria for the diagnosis of PTSD? So in order for an adult to meet the DSM-5 diagnostic criteria for PTSD, we must start by considering their exposure to things such as people dying, or them being at risk of dying, or some other major traumatic event. And that has to be in the sense of they've had either direct experience or have been a witness to that, or have a very close friend or family member who's affected by the experience. or they've been repeatedly exposed to distressing details about the experience to an extent that formulates a traumatic event. We can see that doctors and nurses would meet this first criterion of PTSD, specifically with regards to the coronavirus pandemic, in the sense that they were personally present in hospitals when patients were being admitted with coronavirus and when patients were dying from coronavirus. And in fact, patients, or rather doctors and nurses who weren't directly working in ICU, will have been affected in other ways, for example, being transferred, being asked to help, or it impacting on the care that they were providing to patients in other wards. It also impacted the climate, the atmosphere. The atmosphere was one of panic, where patient mortality was high, where the risk of infection was high, and where the risks could be transmitted from ward to ward. If, for example, one was walking from one ward to the next, or if cleaning staff were responsible for different wards. So secondly, in order for an adult to meet the DSM-5 diagnostic criteria for PTSD, they have to have suffered intrusive symptoms connected with the exposure to people dying, or the risk of them dying, or any other source of trauma such as I've defined shortly before this. So the intrusive symptoms are in the sense of someone repeatedly remembering the experience, even if they don't want to remember it, they don't want the memories. It would involve someone having recurrent unpleasant dreams about it, or having real-life flashbacks, feelings of where they're reliving the experience, and this is known as having a dissociative reaction. Or someone feeling immensely distressed or reacting in a physiological sense, such as shaking or sweating, when they see, hear, or read things which they feel remind them of the experience. Thirdly, in order for an adult to meet the DSM-5 diagnostic criteria for PTSD, they have to persistently avoid memories or external cues which they associate with a traumatic experience. So this persistent avoidance needs to be something which a clinician would see as something that's in excess of what would be, accepted or expected in such circumstances. So the avoidance behaviors can be something that it can be quite distressing. Fourth, they have to have symptoms of impaired mood or cognition, and the sense of exhibiting two or more of symptoms, such as impaired memory about the experience, negative self-esteem, prolonged negative emotions, having a distorted idea about what caused the experience or what happened because of it, feeling detached or estranged from other people, feeling disinterested in important activities, and persistently feeling unable to feel positive emotions. Fifth, in order for someone to be diagnosed with DSM-5's criteria for PTSD, they have to have experienced two symptoms from a list of symptoms connected with certain aspects of their behavior, and more specifically connected with their sense of physiological or psychological reactivity. Now, what does this mean? For instance, someone might find themselves increasingly irritable, more and more angry with things, perhaps reckless or self-destructive. They might find themselves hypervigilant, so this is where they feel more suspicious or more concerned or more attentive to external cues. They might find themselves easily startled. Perhaps they may find themselves finding it difficult to concentrate on things, or finding it hard to fall asleep or staying asleep. And the sixth cluster of symptoms, really, in order for an adult to meet the DSM-5 criteria for PTSD, is they have to have suffered the symptoms for at least a month or more. And by that I talk about the second, third, fourth, and fifth set of criteria that I've just talked about. And seventh, they can only really be diagnosed with PTSD if the symptoms cause levels of distress that are clinically significant, and the sense of impairing the way that they function as a worker, the way that they function in social relationships, or in any other vital aspect of their functioning. And finally, PTSD can only be diagnosed if the symptoms are not caused by medication, they're not caused by drugs, and they're not caused by any other physical or mental disorder. Now, there is a specifier here, and in some cases, clinicians may notice that someone who meets the criteria for the diagnosis of PTSD has a sense of being depersonalized or being having what we call derealization. Now, examples of this, and these are called dissociative symptoms, when someone feels that they are outside their own body, feel that they're outside their own mind. They may feel they're in a dream, or if the world they're living in is unreal or dreamlike. And in that case, a clinician can specify whether they have a diagnosis of PTSD accompanied by dissociative symptoms. Now, I've given you an idea of those diagnostic criteria just to tell you how specific it is that clinicians have to delve into the symptoms that someone has before deciding that they have PTSD. As we can see, having PTSD isn't a case of showing one or two symptoms or having distress for 1 or 2 weeks. One has to have met a series of very thorough and rigorous criteria, and we can see that it's something which requires clinical training and clinical expertise to diagnose. Now that we've considered the coronavirus pandemic from the lens of doctors and nurses, in the sense of what was happening around them and why the pandemic was a traumatic event, let's now examine the data about the prevalence of PTSD, now that I've clarified to you what PTSD is and how it is diagnosed. Now, my preference when I'm talking about such data is to examine systematic reviews and meta-analyses, but we have to accept that it will take time for these to come about. It'll take time for the diagnoses to happen, for studies about PTSD rates to be published, and therefore for somebody to go and conduct a systematic review and meta-analysis. I will talk to you about one such systematic review and meta-analysis later on in this talk, but I do know that others are probably underway as well. So I will consider the prevalence of PTSD among doctors, nurses, and other healthcare staff among similar pandemics or other sorts of outbreaks. And the reason why I will consider evidence involving other healthcare staff, not just doctors and nurses, is because other frontline healthcare staff played an important role during the pandemic. For example, ambulance staff, but also because a lot of the researches that I've been looking at, their publications combine doctors, nurses, and other frontline healthcare workers. So we have very little data about doctors specifically or nurses specifically. So I'm going to look at similar pandemics or similar outbreaks previously. And I say similar in the sense that they have similar characteristics in terms of patient mortality rates or the social significance or the public health significance that the outbreaks had. And I'm focusing on trying to help you understand why PTSD rates are concerning. And we're actually going to talk about the data itself shortly. Now, a study by Wild et al. In 2021 in the British Journal of Clinical Psychology conducted structured clinical interviews for DSM-5 of just over 100 frontline healthcare staff, and that included nurses, doctors, and ambulance staff, and others. The study found that 43% met the diagnostic criteria for PTSD. And that's a very concerning percentage there. Another study by Green et al. In 2021, published in Psychiatric Research, asked a sample of over 1,000 healthcare workers to complete a measure based on the International Classification of Diseases criteria for the diagnosis of PTSD. The study found that 22% of the healthcare workers met the diagnostic criteria for PTSD. So therefore, you see from these two studies alone, we can see rates of between 22% to 43%. Now, we don't know which is which, or rather, we don't know which is more reliable, or rather, indeed, what is the pooled prevalence, because we have to wait for a future meta-analysis to be conducted based on a larger number of studies. Now, having written about and taught using published studies about prevalence relating to a variety of mental disorders, I can tell you that if indeed 22 to 43% are representative, they do appear extremely high. Now, the emerging data shows us a concerning picture and suggests that PTSD rates among frontline healthcare staff after the coronavirus pandemic are concerningly high. Before I continue, I will encourage future researchers to adopt an approach that tabulates PTSD rates per occupational group, because I'm interested in finding out what the rates are among doctors, what the rates are among nurses, and so on, because they have different professional responsibilities, and it's important to consider rates per occupational group in my view, really. Hill et al. In 2022 published a systematic review of 43 studies about rates of a range of mental disorders among healthcare workers following coronavirus, following Ebola, following SARS-CoV-1, and following MERS, and they published that in the Journal of Advanced Nursing. The review found that the prevalence of PTSD was the most common pandemic-related mental disorder, and the pooled prevalence of PTSD among healthcare workers during the pandemics was really 25.8%, which is quite high. Now let's consider the question of what can help doctors, nurses, and healthcare workers suffering from PTSD. We've seen that a significant proportion of them are likely to be affected. It could be anything up to 25.8%. It can be even as high as 43%. At this point, we don't know, but we do know that the numbers are many. We do know that we have hundreds of thousands of doctors, we have hundreds and thousands of nurses in the United Kingdom. And so the prevalence is not just high, but actually an emergency, really. So what can we do to help? What can organizations do to help them or support them? Now, when being asked about how to help a resilience, because I was asked to talk about resilience in this talk, I will clarify that I'm critical of the word resilience, especially when it is applied to the study of mental disorders, because the word resilience implies that a person's recovery from something relies upon them having a certain personality characteristic, a certain trait, a certain tendency, and that implies a sense of blame. Now, if people are finding it difficult to cope with a mental disorder, that is actually an inherent component of having the mental disorder. It's not a lack of resilience. It's not a lack of the ability to cope. It's nothing to do with their personality. They can't be blamed for not having developed a resilient personality trait, and I put resilient in quotes, or a so-called resilient tendency to cope well enough. They can't be told that they could have coped better if only they did X, Y, Z, or if only they completed resilience training, or told that they might not have developed PTSD if only they had had resilience training. No, absolutely not. We know that's absurd, because people can't be blamed for having a mental disorder any more than they can be blamed for having a physical illness. It's simply not their fault. So regarding what can be helpful in cases of PTSD, what I did for you today in considering how to advise you if you're interested in understanding more about this, is I kind of looked at meta-analysis by Watts et al. Published in 2013 in the Journal of Clinical Psychiatry, and it examined 112 studies about treatment interventions for PTSD. And the meta-analysis was interested in looking specifically at efficacy rates and found that the following kinds of treatments are effective. One is cognitive therapy, two is exposure therapy, the other one is medication such as fluoxetine, paroxetine, sertraline, and other sorts of types of medication whose names are fairly difficult to pronounce. And also, as well as that, another effective treatment was psychotherapy that involved eye movement desensitization and reprocessing. So, from the point of view of businesses and other types of organizations, including the National Health Service, hospitals, clinics, or other types of practice settings worldwide, it's vital to accept and understand that clinicians have a really, really important role in providing support for workers with PTSD. So this is not something that can be dealt with by people who work in HR, people who work in occupational health, or consultants, or anything else like that. The people who can provide the care for workers who have PTSD, including doctors and nurses with post-pandemic PTSD, is for people who are clinically trained to provide appropriate psychotherapies and or appropriate pharmacotherapies. Because really most cases it can really only be provided by trained clinicians. But what organizations can actually do to support doctors, nurses, and other healthcare staff if they're suffering from PTSD, or if they're suspected to be suffering from PTSD, or indeed if they have disclosed that they are concerned that they might be suffering from it, is to connect them with appropriate clinical support. This could either really be in terms of encouraging doctors, nurses, and other workers to seek support from their GP and a referral, or to provide appropriate support that is clinically approved. For example, in international settings, there might be access to private medical care or anything else which is helpful in that sense. And the other thing that could be really helpful is really giving employees, doctors, nurses, and other workers information about what PTSD, and that's going to help them realize what it is and realize when it is they may need support or help. And it may help in stopping or reducing the stigma that exists about accessing mental health treatment. Talking about PTSD, being open about it, helping people understand what it is, will hopefully help reduce the sense of shame, or that people castigate people with it, where they don't. It's mostly out of ignorance, of not knowing what PTSD is. But it's also important to tell doctors, nurses, and other healthcare workers just how prevalent it is after the coronavirus pandemic, and how prevalent it is after other sorts of pandemics. And helping them understand that will help them understand that they're not alone. It's not just them, and it's something that is normal and expectable, or rather that is, in some cases, an unfortunate, inevitable consequence of working in such a traumatic context as the coronavirus pandemic in hospitals and other clinics and healthcare settings at the time. Now, I also recommend improving staff awareness about PTSD in hospitals and other healthcare workplaces. So help workers to understand what exactly the healthcare system can do to help them. What is the chain of contact or referrals? And this really, I speak to international audiences, because in the NHS we may understand how things work there, but organizations will need to tailor the advice to suit whichever context they are working in and how the healthcare system works there. So organizations can help by encouraging doctors and nurses to seek help, by normalizing help-seeking behavior, and by making it easy to access confidential and free from judgment help and support. Now, finally, I want to close my talk by talking about some broader strategies which healthcare workers should consider using in the event of a future new wave of the coronavirus pandemic, or in the event of any other disease outbreak. Now, include this also for the benefit of anyone listening to this talk who'd like some evidence-based advice about how to cope with potentially traumatic workplaces. Some aspects of the advice are specific to healthcare workers, such as concerning PPE, but you can more broadly extrapolate ways of applying the advice to your own workplace as well. Now, I and my colleague Ppe Shortage developed the advice when we were writing a fact sheet for NHS staff during 2020, the first year of the coronavirus pandemic. And we developed the following tips based on what we've read within the published studies about how healthcare workers were trying to cope, and did in some cases successfully cope, with the stresses of SARS-CoV-2, SARS-CoV-1, MERS, and Ebola. So the first thing that I would advise is use psychology to manage distress. So learn what occupational distress is. If you want to know about PTSD, for example, or any other mental disorder, I encourage you to learn about it. Find out about what it is, because demystifying it can be quite psychologically powerful, because knowledge is power. 2, try and access psychological support services, as I discussed previously. 3, try and get support for your distress from your family members. Talk about what you're experiencing and make sure you disclose it to family members or loved ones. 4, try and chat with them about your fears. be open and honest about what's happening. What are you afraid of? What are the deep fears that you have about what's happened or what's going to what's likely to happen, for example. Fifth, try and, as much as possible, and it can be difficult, but if at all possible, try and psychologically detach yourself from the pandemic in your free time. Try and not look at the news, and this is the sixth point, avoid excessively reading COVID-19 news or news relating to any other kind of outbreak or trauma that may be triggering distress. Seventh, during lunch breaks or your free time, try and watch entertainment that's unrelated to the pandemic. So try and kind of move away from news outlets, media, commentary, or anything like that keeps reminding you about the pandemic or something else that's distressing. And eighth, try and make time for recreational activities every day. That can include aerobic exercise such as running, brisk walking, or cycling. And that's because we know that aerobic exercise can be very, very beneficial for mood and mental health. The second cluster of advice that we developed in our NHS fact sheet for the NHS was we encourage staff to use infection control to manage distress. So actively, if at all possible, that's if you're given PPE, try and manage the notion of infection control. Immerse yourself in trying to reduce the risk that you have of being infected with a virus or any other kind of infectious disease. And for example, you can firstly try and advise your family about what sorts of protective measures they can take so that they reduce your anxieties about them getting infected. So advise your family and loved ones about using face masks and other sorts of protective equipment, be it gloves or face shields in addition to face masks and so on. Secondly, use PPE rigidly, because that has been shown to reduce anxieties that people have within healthcare settings about they themselves, their colleagues, or patients getting infected. Third, try and avoid thinking about the anxieties that you have. So outside work, try and use the protective measures that you have to reduce the anxieties about the infection. So rather than perhaps being anxious about the infection, use PPE equipment outside of work, or rather more correctly, protection measures outside of work, so that you that way reduce the anxieties that you might have about being infected. And fifth, within this cluster of advice, we recommend that you learn about virology of COVID-19 or learn about anything else that's relevant to the outbreak. For example, if it's some of the sort of outbreak like Ebola or any kind of bacterial or viral related outbreak, try and learn about the science behind it. Keep up with the latest evidence. Try and look at major journals. If you're in medicine, you'd be looking at places like JAMA, Lancet, BMJ. If you're in general science, you'd be looking at Nature and Science, and so on. So try and stay well informed about the virus or the bacteria or whatever it is, and try and stay well informed about the best practice in infection control. Now, that sense of being informed can be quite powerful. As I said earlier, knowledge is power. Now, the next cluster of advice concerns, we would recommend you harness organizational support. We know that support from your organization in terms of what you can do to protect yourself against infection can be psychologically beneficial. First thing is, speak up about the lack of PPE. Now, this applies not just in healthcare settings, but really in any other kind of workplace, unless you're working from home. Try and speak up about the lack of PPE. Try and speak up about policies relating to what sorts of protective measures people should wear. If your workplace doesn't have a mandatory face mask use policy and you're concerned about an outbreak, then try and raise the subject of this policy becoming mandatory. Because speaking up will help you feel better about it, but getting support from your organization will also help you feel better about it. Secondly, Ask for things that make you feel valued. Now, if there's something that you feel your organization can do to help you feel that you're better protected and you're better valued as a worker, then do ask for them. Now, this can be specific to your sector. If you're working in the healthcare setting, then you should, request that your organization is quite clear to patients about the expectations towards them, or clear to visitors of patients about what the expectations are towards them, in the sense of protecting doctors, nurses, and other healthcare staff from infection. So ask for things that will make you feel better valued by your organization, in the sense of protecting you from infection and potential death. Third, ask your supervisor to support you. If your supervisor or manager isn't being supportive, that can be very, very, very stressful. We know that that's one of the biggest stresses, really, more generally, in understanding workplace stress. But with regards to dealing with a pandemic or an outbreak or some other kind of traumatic event, it's really important to get supervisor support. And if you don't have it, then do complain. Now, fourth, attend training about COVID-19 or the outbreak that you're facing, or other sorts of trauma that you may be coping with. If you don't have that training available, ask your organization to support you by providing that training. Now, fifth, try and discuss ethical dilemmas with other people. If you're working in a healthcare setting, for example, and for example, in the early days of the coronavirus pandemic, there wasn't really enough PPE, and so there were actually ethical dilemmas about how do you use PPE. It's in short supply. There were some doctors and nurses who were facing dilemmas about the washing of the re-washing or re-cleaning of PPE equipment that is for single use, for example, or indeed the use of face masks that are not meant for medical settings, but using them in medical settings. That's an ethical dilemma if you're a medical professional. And you might be dealing with ethical dilemmas that are of other sorts of kind, depending on your sector, that are related to the trauma that you've been experiencing. The sixth thing that we recommend is to belong to a union or association that is going to support you in demanding appropriate organizational support. Seventh, speak up about a supervisor who's bullying you. Now, if you've requested, for example, PPE, and you're finding that becomes a point of contention because you're being penalized for speaking up, speak up about it. Because not speaking up about a bullying supervisor might wind up being something that exacerbates the stress that you have as a healthcare worker dealing with a pandemic or the outbreak. So trying to speak up will be helpful in trying to kind of mitigate your sense of stress. Of course, whether they will do anything about it is another matter, whether speaking up in and of itself can be quite helpful as well. And eighth, try and request extra resources you need. For example, you might need information, you might need improved technology, you might need improved physical facilities, or anything else that you might need your organization to do to help. Ninth, we recommend that you build a social support network at work. Talk about the kind of fears that you have about the pandemic or the outbreak or the source of trauma. Try and talk about it quite sort of openly and candidly with other colleagues, because chances are they'll be experiencing the same thing. And talking about it can be really, really helpful. And finally, and this is a more sort of broader point, try and chat with your colleagues. Don't alienate yourself. Try and talk to other people in your workplace, because that sense of social identity that will be promoting and harnessing is going to be also quite beneficial in giving you that sense of organizational support. Now, the next kind of advice that we have is to use self-compassion. So first, be self-compassionate about your fears. Second is try and have a positive attitude wherever possible, although of course that's not always feasible really in the middle of a pandemic. And so I'm very wary of saying to have a positive attitude when all around you is negative. But third, try and take care of your emotional needs. If you're feeling unhappy with things, if you're feeling pessimistic about things, then try and take care of your emotional needs by perhaps being compassionate about them. Give yourself the license to feel what you're feeling about the COVID-19 outbreak, or about any other kind of outbreak you're dealing with, or indeed any other kind of source of trauma that you're dealing with in the workplace. Fourth, talk to yourself. Try and encourage yourself. If need be, write a diary to yourself or write a journal. Try and be encouraging to yourself. Don't point the finger at yourself or blame yourself or think that you're not being resilient enough, you're not coping well enough. Try and see it as something which is simply happening outside of your control. So be kind to yourself. Fifth, avoid pessimism and negative emotions, even though of course those are very difficult to control. But if at all possible, if you're, for example, applying some of the other elements of advice that I talked about earlier. So, for example, if you're talking with your colleagues about what's happening, avoid pessimism and avoid negative emotions, because those aren't going to be helpful to you. Although you can't control your emotions, you can control how you talk about them or what prominence you give to them. So try, if at all possible, avoid them. Now, sixth, think about colleagues who recovered, for example, from COVID-19 or whichever outbreak you're dealing with at the time. Because thinking about colleagues who recovered will reduce your own anxiety about being infected, and it will reduce your anxiety about potentially dying. It doesn't mean that those risks, those infection risks, aren't there, but trying to weigh up the data or weigh up the probability that you will be fine can be helpful in reducing the anxieties. And finally, think about patients who recovered to reduce your anxieties about just how risky the patient's lives are, or how risky their symptoms are, and so on. This is not to say that you're going to diminish your kind of approach to acute or life-threatening symptoms. But in situations where you think about positive outcomes, patients who walked out of hospital and you see them out there, or you hear of them out there and they're alive and well, those sorts of positive stories can help you feel encouraged and help you feel less anxious about being infected with COVID-19 or any other kind of threatening virus or type of infection. Now, I'd like to conclude this talk with an encouraging word to doctors and nurses who are listening to my talk. The coronavirus pandemic was a catastrophic event. Society really owes a debt to you, doctors, nurses, and other healthcare staff, for all the efforts that you put into caring for patients in the face of so much adversity. In the periods when there were no drugs, there were no vaccines against the virus, and even in many cases there was no PPE, and yet you doctors and nurses pressed ahead and you did the best that you could. You persevered in times when working in a hospital was putting you at risk of infection or death. And really your efforts and self-sacrifice saved many lives. And that, to me, is one of the best examples of resilience that we can ever hope for in a workplace setting at all. So the way that doctors and nurses and other healthcare staff made it through the pandemic is in and of itself an example of resilience to me. And for that, we as a society thank you profoundly. Now, many doctors, nurses, and other healthcare staff died as a result of contracting coronavirus at work, and we remember them in our thoughts and our prayers.